I'll be sharing the initial findings of a project joined with a former PhD student, Dr. Nandini Rakala, who is currently an Oak Ridge Fellow at the FDA, and Dr. Ersoy Subaşı, a faculty in computer engineering and sciences at Florida Tech. So in our project, we adopt a data-driven approach that complements the traditional hypothesis-driven research in medical studies, as Dr. Al-Ghatrif presented. We know that most complicated human diseases are caused by complex interactions among multiple factors such as gene-gene interactions, environmental factors, lifestyle and dietary habits, and underlying health complications such as chronic conditions. So it's clear that COVID-19 is one of those complicated diseases, and therefore it's essential to identify the factors associated with COVID-19 deaths. As an initial attempt to increase our understanding of this disease, we analyzed the COVID-19 data set collected by Johns Hopkins University's Center for Systems Science and Engineering. So the original data set was collected from January 22nd to March 31st and contains actually records for over 261,000 COVID-19 patients from more than 30 countries, including United States and China. But out of those 261,000 patients, we know that 491 of them recovered and 176 of them died. And for each of these patients, the data also includes more than 30 features varying from age, gender, location of the patient, in addition to geographic location, to the date of onset symptoms and previously known chronic conditions. So in our initial analysis, we have identified several significant factors associated with COVID-19 outcomes of being recovered or death, as shown in this figure. So the figures are hard to see, but I will be briefly explaining some of the observations we had. The first one is that 50% of the COVID-19 patients in this data set, whether they recovered or died, had a combination of one or more of chronic conditions such as hypertension, diabetes, asthma, and chronic kidney disease. While this reinforces the importance of paying attention to patients with chronic conditions, it also shows that having a chronic condition by itself cannot be used as a strong predictor of the COVID-19 deaths. We also observed that those patients who ended up dying from COVID-19, the average number of days from severe symptom onset such as acute respiratory failure, pneumonia, septic shock, or fatigue to confirm diagnosis was a day and a half. For the patients who recovered, the number of days from mild symptoms such as cough and fever to confirm diagnosis was 3.5 days on average. When compared, we see that cases of COVID-19 in United States, whether resulting in recovery or death, were about 50 years old, whereas in China, the range was far broader, from 19 years old to 80 years old patients. Another interesting observation that we had in our analysis is that the large number of confirmed COVID-19 cases in the studied outcomes in this data set were found in locations with low latitude and high longitude. In summary, our analysis show that having a chronic condition or age or any other factor by itself cannot be used as a strong predictor of COVID-19 deaths. With the machine learning approach, we are able to not only identify a collection of significant risk factors that can, in combination, help us understand the risk of death, but also enables us identify patterns associated with COVID-19 outcomes. For example, one of the patterns associated with COVID-19 deaths outside of Wuhan is having a chronic disease, a geographical location with high longitude and low altitude, and having less than 3 days between symptoms onset and diagnosis of the disease. So we continue our investigation in this direction and hope to involve medical experts in our study and share our findings with the scientific community in the near future. And with this, I would like to conclude my talk.
Dr. Subasi, thank you very much. We have time for one question which came in, and that is, where do you see your research going next?
So in all these data science studies, we definitely need the input from our medical collaborators. And we will be just making sure that we use the most up-to-date data. So that by the time we did this analysis, the data set was collected from January 22nd to March 31st, but another 2 months passed, so it means that we have more data available. So we will be redoing this analysis, verifying the significant factors, sharing it with medical collaborators, and then seeing that if any of these would help for clinical interventions like drug development.
Thank you. Thank you very much.